Harold Shipman, The Deadly Doctor, Full History. Harold Frederick Shipman, 14th of January 1946 to 13th of January 2004, nicknamed Dr. Death, or The Deadly Doctor, was an English general practitioner, GP, and one of the most prolific serial killers in modern history. A seemingly respected family doctor in Hyde, Greater Manchester, he murdered his patients by injecting lethal doses of diamorphine, medical heroin, and then falsified medical records and death certificates to make the deaths appear natural. He was convicted in 2000 of 15 murders, but the official Shipman inquiry, 2002 to 2005, concluded he had killed at least 215 patients, with strong suspicion in another 45 cases, for a total estimated at around 250 over roughly 27 years. The vast majority of victims were elderly women who trusted him completely. Early life and education, 1946 to 1970. Shipman was born on a council estate in Nottingham, the second of 3 children in a working-class Methodist family. His father, Harold, was a lorry driver. His mother, Vera, was domineering and the center of his world. He was academically bright, but a loner at High Pavement Grammar School. In June 1963, when he was 17, Vera died of lung cancer at age 42. Shipman witnessed her doctor visiting the home to administer morphine injections that eased her pain in her final days, an experience that later eerily mirrored his own killing method. He married Primrose Oxtoby, whom he met at a bus stop, in November 1966. She was already pregnant with their first child. The couple went on to have 4 children and remained married until his death. In 1970, he graduated from Leeds School of Medicine and began work as a junior doctor at Pontefract General Infirmary in Yorkshire. Early medical career and first red flags, 1970 to 1977. After Pontefract, Shipman became a GP at the Abraham Ormerod Medical Centre in Todmorden, West Yorkshire, in 1974. In 1975, he was caught forging prescriptions for pethidine, an opioid painkiller, for his own addiction. He was fined £600, attended a brief drug rehabilitation program, and left the practice. Remarkably, given the era's lax oversight, he was allowed to return to medicine. In 1977, he joined the Donnybrook Medical Centre in Hyde, Greater Manchester, where he built a reputation as a dedicated, hard-working doctor who made house calls and cared especially for elderly patients. Solo practice in Hyde and the killing spree, 1977 to 1998. By 1993, Shipman had his own single-handed surgery at 21 Market Street, Hyde. He was well liked in the community and even appeared in a 1983 Granada television documentary, World in Action, discussing community care for the mentally ill. Behind this facade, he was systematically killing patients. Method and pattern. During afternoon home visits, Shipman would inject a lethal overdose of diamorphine, which he obtained legitimately or stockpiled. Victims died quickly and peacefully. He would then alter computer records to suggest the patient had been in poor health, for example, heart disease or cancer, sign the death certificate himself, attributing death to old age or natural causes, and often arrange cremation to destroy evidence. No postmortems were usually requested. Victims. The Shipman inquiry, chaired by Dame Janet Smith, examined hundreds of deaths and confirmed he unlawfully killed at least 215 people between 1975 and 1998, plus strong suspicion in 45 more. A later statistical review raised the total to around 250, possibly beginning as early as 1971 at Pontefract, including suspicion around the death of a 4-year-old girl. Roughly 80% were women. Most were elderly and living alone, though some were younger or in better health than he claimed. He killed at a varying rate, sometimes one every 10 days in the mid-1990s. Motive: never fully explained. He denied everything and offered no confession. Theories include a godlike sense of power, a distorted belief in euthanasia, removing burdens from the NHS, or a psychological link to his mother's death. Financial gain was not a primary driver, except in one forged will, and there was no sexual element. He was described as arrogant, controlling, and emotionally detached. Discovery, arrest, and trial, 1998 to 2000. In March 1998, neighboring GP Dr. Linda Reynolds noticed Shipman's unusually high death rate, especially among elderly women whose cremation forms she was asked to countersign, and alerted the coroner. A police investigation was cursory and closed in April 1998 with no evidence of wrongdoing. Shipman killed at least 3 more patients afterward. The breakthrough came on 24 June 1998 with the death of Kathleen Grundy, an 81-year-old fit former mayoress of Hyde. Shipman certified old age. Her daughter, solicitor Angela Woodruff, became suspicious when she discovered a crudely forged will, typed on Shipman's own brother typewriter, leaving Grundy's entire £386,000 estate to him. Grundy's body was exhumed. Toxicology showed fatal levels of diamorphine. Police exhumed 15 other bodies and found the same pattern: lethal injections, falsified records, and clustered deaths after Shipman's visits. Shipman was arrested on the 7th of September 1998. His trial opened on the 5th of October 1999 at Preston Crown Court. He faced 15 counts of murder, victims aged 49 to 81, all killed 1995 to 1998, and 1 count of forging Grundy's will. After 6 days of jury deliberation, on 31st January 2000, he was convicted on all charges. Mr. Justice Forbes sentenced him to 15 concurrent life terms with a whole life tariff, no possibility of release. He was struck off the medical register by the General Medical Council on the 11th of February 2000. Throughout, Shipman maintained his innocence. His wife Primrose stood by him and visited him daily in prison. Imprisonment, suicide, and aftermath, 2000 to 2004. Shipman was held at HM Prison Wakefield. He refused rehabilitation programs, made few friends, though he befriended fellow serial killer Peter Moore, and continued to deny any wrongdoing. On January 13, 2004, 1 day before his 58th birthday, he hanged himself in his cell using bedsheets tied to the window bars. His suicide meant he never confessed, and victims' families felt denied closure. A 2005 review found the suicide could not have been predicted or prevented under the rules then in force. His body was held for over a year for security reasons before private cremation in June 2005, attended only by his widow and children. The Shipman Inquiry, 2001 to 2005, and Legacy. The public inquiry, led by Dame Janet Smith, produced 6 reports at a cost of £21 million. It examined 888 deaths, took thousands of witness statements, and concluded Shipman had killed at least 215 patients, possibly 250 plus. The inquiry exposed catastrophic systemic failures. Single doctors could certify deaths without independent checks. Cremation forms were rubber-stamped. No routine monitoring of GP death rates or controlled drug stocks. Police and coroner investigations were inadequate. The General Medical Council was seen as protecting doctors rather than patients. Major reforms triggered. Introduction of medical examiners to scrutinize deaths. Tighter controls on diamorphine and other Schedule II drugs. Mandatory death rate monitoring for GPs. Changes to cremation certification and coronial law. Restructuring of the GMC to prioritize patient safety. The Shipman effect made many doctors more reluctant to prescribe strong opioids, sometimes leading to undertreatment of pain. A memorial garden, Garden of Tranquility, was opened in Hyde in 2005. Over 200 families received compensation. Shipman remains Britain's worst convicted serial killer by victim count, and the case continues to be studied in medical ethics, criminology, and public inquiry literature. His crimes shattered the sacred trust between doctor and patient in the UK and led to lasting safeguards that protect millions today. Despite exhaustive investigation, his exact motives and the full extent of his killings remain, in the end, known only to him. The Shipman Inquiry, 2001 to 2005. Full details. The Shipman Inquiry was a major independent public inquiry into the crimes of Harold Shipman, Britain's most prolific serial killer. Established in the wake of his 2000 conviction for 15 murders, it examined the full extent of his killings, the systemic failures that allowed him to evade detection for decades, and the reforms needed to protect patients. Chaired by Dame Janet Smith, DBE, a High Court judge, it produced 6 reports totaling around 5,000 pages, cost £21 million, took approximately 2,500 witness statements, and analyzed approximately 270,000 pages of evidence. The inquiry investigated hundreds of deaths, initially approximately 618 announced in May 2001, with deeper analysis of 888 cases. Background and establishment. Shipman's conviction on 31st January 2000, 15 murders plus 1 forgery, prompted calls for a full investigation into how a trusted GP could kill undetected for approximately 27 years. On 1st February 2000, Health Secretary Alan Milburn announced an independent inquiry. It began as a private process under Lord Laming, but after a judicial review brought by victims' families and media pressure, was made fully public in September 2000. It was formally established under the Tribunals of Inquiry Evidence Act 1921 in January 2001, with Dame Janet Smith replacing Lord Laming as chair. Hearings were held at Manchester Town Hall, with live relay to Hyde Library for victims' families. The inquiry opened in 2001 and ran until early 2005. It was decommissioned at Easter 2005. Terms of reference. The 4 core areas were: 1. The extent of Shipman's unlawful activities. 2. The actions of statutory bodies and others in investigating patients' deaths. 3. The performance of bodies responsible for monitoring primary care and controlled drugs. 4. Steps needed to safeguard patients in the future. The 6 reports. The inquiry released findings in stages. The first and 6th were primarily factual, establishing the scale of killings. The middle 4 examined systemic failures and made recommendations. 1. First report. Death disguised. 19th July, 2002. Examined how many patients Shipman killed, the methods, and time frame as a GP. Key findings. Shipman unlawfully killed 215 patients between March 1975, first confirmed, Eva Lyons in Todmorden, and June 1998, last, Kathleen Grundy. There was real suspicion in another 45 cases, with a further approximately 200 highly suspicious. He used lethal diamorphine injections and falsified records/death certificates. He was addicted to killing and betrayed the trust of patients and the community in an unparalleled way. Volumes 2 to 6 detailed individual case decisions. Second report. The police investigation of March 1998, 14th of July, 2003. Scrutinized the Greater Manchester Police, GMP, probe triggered by Dr. Linda Reynolds' concerns about Shipman's high death rate. Key findings. The investigation was poorly handled by inexperienced officers. Opportunities were missed. Proper action could have saved Shipman's final 3 victims. No formal recommendations, but highlighted need for better guidance on health professional wrongdoing investigations. 3. Third report. Death certification and the investigation of deaths by coroners. 14th of July, 2003. Analyzed how death and cremation certification failed to detect homicide. Key findings. The system was inadequate for spotting doctor-caused deaths. Shipman exploited it by certifying natural causes and arranging cremations. Called for a complete break with the past. Radical reform, including a national coroner service, medical examiners, and scrutiny of all deaths. 4. Fourth report. The regulation of controlled drugs in the community. 15th of July, 2004. Investigated how Shipman obtained and stockpiled diamorphine. Key findings. Weak controls allowed diversion, for example, collecting drugs for patients who then died. Failures by individuals and systems, including post-1976 pethidine conviction oversight, enabled him. Recommended a controlled drugs inspectorate, audit trails, restricted prescribing, and special safeguards for injectables. 5. Fifth report. Safeguarding patients. Lessons from the past. Proposals for the future. 9 December 2004. Reviewed. GP monitoring, complaints, whistleblowing, and GMC procedures. Key findings. The GMC was an organization designed to look after the interests of doctors, not patients. Poor data monitoring, reluctance to complain, and weak revalidation allowed Shipman to thrive. Over 100 recommendations for radical reform, single complaints portal, strengthened whistleblower protection, systematic mortality/prescribing monitoring, GMC restructuring, and robust revalidation/appraisal. 6. Sixth and final report. 27th January 2005. Extended investigations to Shipman's early career as a junior doctor at Pontefract General Infirmary, 1970 to 1974. Key findings. He killed at least 3 patients there, all men, and probably 10 to 15 more. This brought the confirmed/suspected total to an estimated approximately 250 victims overall, 1971 to 1998, with the true number possibly higher. Provided the most complete picture possible given the passage of time and lack of exhumations in many cases. Overall, conclusions on victims. Confirmed unlawful killings, 215. GP era.
Strong suspicion,
Plus 45.
early career,
Pontefract. Plus approximately 12 to 15.
estimated total,
Approximately 250. Some statistical reviews suggested 236. Victims were mostly elderly women, but included younger patients and at least one child suspicion in earlier analyses. Rate varied, peaking at approximately 1 every 10 days in 1996 to 97.
systemic failures identified.
The inquiry exposed catastrophic gaps: no routine death rate monitoring for GPs, rubber-stamp cremation certification, lax controlled drug oversight, inadequate police/coroner's investigations, a doctor-protective GMC culture, and poor complaints/whistleblowing systems. Shipman's arrogance and the era's trust in doctors enabled him. Recommendations and legacy/reforms. The reports drove sweeping changes implemented via government responses, for example, 2007 CM 7014, Learning from Tragedy. Introduction of medical examiners to scrutinize all deaths. National coroner reforms. Chief coroner. Improved training.
Tighter controlled drug regulations,
Accountable officers, audit trails, safer management of controlled drugs framework.
GP performance monitoring,
Revalidation and appraisal. GMC overhaul. Focus on patient safety, civil standard of proof, independent adjudication.
better complaints handling,
And whistleblower protection.
enhanced clinical governance,
And data sharing in the NHS. Many reforms were enacted through the Health Act 2006, Coroners and Justice Act 2009, and GMC changes. The Shipman effect also led to more cautious opioid prescribing. A 2008 study noted that even improved monitoring might take approximately 30 excess deaths to flag a pattern. Victims' families received compensation. A memorial garden opened in Hyde. The inquiry remains a landmark in UK medical regulation and public safety, fundamentally reshaping how deaths are certified, doctors are monitored, and patient protection is prioritized. Shipman never confessed. His motives and full victim count died with him in January 2004. The reports are archived on gov.uk and the, now archived, official inquiry site for full reading.
Harold Shipman.
Methods. Analysis.
Harold Shipman's methods
Were deceptively simple, yet brilliantly effective for a trusted general practitioner, GP. Over approximately 27 years, from at least 1971 to 1972, as a junior doctor through to June 1998, he killed at least 215 confirmed patients, with strong suspicion in another 45, and a probable total of approximately 250, primarily by lethal intravenous I5 injections of diamorphine. The Shipman Inquiry's first report, Death Disguised, July 2002, concluded, Shipman's usual method of killing was by the administration of a lethal dose of an opiate, most frequently diamorphine. There is some evidence that he may have killed a few patients by the administration of large doses of a sedative. There is no reliable evidence that he killed by any means other than the administration of a drug. His approach exploited his medical authority, patients' trust, weak regulatory systems, and the era's lax death certification processes. No sexual motive, financial gain, except one forged will, or sadism was evident. Victims died peacefully, often without realizing anything was wrong.
1.
The killing agent, diamorphine, pharmaceutical heroin. Drug, diamorphine hydrochloride, a potent opioid used legitimately for severe pain, for example, terminal cancer. It metabolizes rapidly to morphine in the body.
Dose.
Massive overdoses, typically around 30 milligrams IV, 6 times a standard therapeutic dose, normal analgesic starting dose, approximately 5 milligrams. In one documented instance, he prescribed and collected 12,000 milligrams in a single patient's name, enough to kill hundreds. Effects. Onset in 1 to 2 minutes, full respiratory depression, coma, and death within 5 to 10 minutes from hypoxia.
Appearance.
Victims often turned blue/pallid, appeared to have suffered a sudden heart attack or stroke, perfectly plausible in elderly patients.
Sourcing.
Legitimate NHS prescriptions in patients' names, often fabricated terminal illness. He overprescribed, collected drugs personally from pharmacies, and stockpiled excess, mirroring his 1970s pethidine addiction. No effective audits existed. Post-1976 conviction oversight was minimal. 2. Victim selection and opportunity.
Profile.
Approximately 80% elderly women, 79.5% female overall, aged 65 to 93, some younger, living alone, often widowed or isolated. They trusted Dr. Shipman completely. Many regarded him as a caring, house-calling doctor. Timing and setting. Almost exclusively afternoon home visits when victims were alone. Pretext, routine check, minor complaint, or just passing. Patient held out their arm trustingly for what they believed was a helpful injection. Pattern, sudden, unexpected death shortly after visit. Shipman was often the last, or only, person present. Rate escalated dramatically in single-handed practice. Post-1992. Up to 1 killing every 10 days in 1996 to 97. 3. Immediate aftermath and cover-up. At the scene. If death occurred in his presence, he sometimes phoned for an ambulance, then cancelled it, claiming the patient had died peacefully. He left bodies to be discovered by relatives later, behaving abruptly, for example, leaving doors unlocked.
Death certification.
Signed Medical Certificate of Cause of Death, MCCD, himself, claiming old age, natural causes, myocardial infarction, or chronic conditions. Avoided coroner referral in nearly all cases by claiming certainty of diagnosis and persuading families against post-mortems. Cremation. Strongly encouraged or arranged cremations, destroying all physical evidence. High cremation rate among his patients was a red flag ignored until 1998. 4. Digital and paper record falsification, the backdating technique.
Computer records.
Used his surgery's EMIS computer system to create or alter entries after the death, but backdated them by weeks/months, up to 6 months. Examples from trial/computer audit trail. Added invented symptoms, angina, chest pain, cancer, to suggest long-term illness. Police forensic expert found audit logs proving entries were made post-mortem. For example, 3-minute burst of entries for one victim immediately after injection.
Paper notes.
In some cases, added handwritten or typed false notes, for example, claiming drug abuse in Kathleen Grundy to explain toxicology.
Typewriter forgery.
Grundy will. Used his old brother manual typewriter for the forged will and letters. Crude uppercase typing with characteristic missing letters / malfunctions matched exactly to the machine in his surgery. This digital trail was decisive in the 1998 to 2000 investigation. 5. Statistical and behavioral patterns. Clustering. Deaths clustered in afternoons. High volume in single-handed practice. Trophies. Small personal items, jewelry, watches, sometimes missing from victims' homes, found hoarded in Shipman's garage. Minor financial motive in isolated cases. Early career variations. Possible hospital killings. 1970 to 74, used similar opioid overdoses. One confirmed sedative case.
No confession.
Shipman never explained methods or motives, denied everything until suicide in 2004. 6. Forensic detection and breakthrough. Toxicology. Exhumed bodies showed massive morphine levels in skeletal muscle. Diamorphine metabolite persists years in buried remains. No prescribed morphine history.
Computer forensics.
Audit trail exposed backdating. Circumstantial. Death rate anomalies, cremation forms, forged will. Trial. Convicted on 15 cases, 1995 to 98, using mix of toxicology, records, and witness evidence. Cremated victims relied on records alone. Why it worked for so long. Systemic exploitation. Minus doctor-patient trust plus single-handed practice equals no oversight. 1970s to 90s. UK. No routine GP death rate monitoring, rubber stamp cremation. Form C. Weak controlled drug audits. Shipman's arrogance plus plausible, caring doctor persona silenced doubts. Inquiry verdict. He disguised death perfectly within a flawed system. Psychological and criminological insights. Experts describe a God complex, power over life/death, possibly linked to his mother's morphine-eased death in 1963. No empathy shown. Victims were burdens or experiments in control. Unlike most serial killers, no violence or sexual element, pure clinical efficiency. Legacy. His methods exposed fatal gaps, leading to medical examiners, controlled drug audits, GP revalidation, and death rate monitoring. The Shipman effect still influences cautious opioid prescribing today. Shipman's methods remain a textbook case in forensic medicine, criminology, and healthcare safety, showing how ordinary medical tools, when wielded by a calculating insider, can enable mass murder on an industrial scale. The full inquiry reports, especially First Report, Volume 1, provide the definitive technical analysis.